Welcome to Lecture 5, Billing and Pricing for Pharmaceutical Services and Marketing. In our prior lectures, we talked about the importance of how pharmacy services can assist and play a big role in partnering with payers, providers, and for patients. These services can help improve outcomes, especially significant costly outcomes such as hospitalizations and ER visits. We talked about the ability to do business planning to develop these services, and we talked about the needs for having appropriate workflow. And during that workflow, we talked about the collection phase and the assessment phase. Well, just like when you're billing a prescription, it's important to know that billing for a service is very similar. That when we're billing a prescription, what do we need to do? We need to document several things. The drug, and we identify the drug how? By the NDC number. We also have the quantity, the day's supply, calculated based upon the directions. In addition, we also have the cost and any other additional codes that might be needed in order for the payer, most likely the pharmacy benefit manager, to pay it. If there's ever a med error, we document what occurs in that error. So documenting a clinical service is very similar. Some of the reasons why we document is one, to our own clinical reasoning, to monitor the patient's progress. It serves as the clinical and legal record for what we collected and how we made our assessments from what we collected and how we planned and implemented based on our collection and assessment. This is also very important, and this is what we're going to discuss, of documentation is very important on how we're going to get reimbursed and how we're going to document in order for people we may partner with, like physicians, to get paid. Documentation is also a way that we can go back and collect data to evaluate successful outcomes in humanistic, clinical, and economic. And documentation, as I said, is pertinent to be able to provide a service by collecting important information such as patient history, medications, assessment, and plan. It's also important that in the era of 2019 and beyond, that when we document, we are not going to document how we were traditionally taught. Traditionally, we were taught how to write a SOAP note, to write out your thoughts on a piece of paper and document in a chart of what you did. I'm not saying that we're not going to document that information, but in order to share that information with providers and payers in order to get paid, there has to be some standardization of documentation, just like there is when we fill prescription. And when we share that information, whether it's with a payer or sharing it with the electronic health record of a provider, we need to talk the same language and be in the same format as other providers. And so what has been developed over the last several years is health information exchange. This health information exchange committees that have been discussing and developing the ability for all healthcare providers to interact is developing standardization coding for this to occur. We're going to talk about CPT codes here in a second, but the one thing that was created was called SNOMED CT codes. And these are systemized nomenclature of medicine clinical terms. So they're standard clinical healthcare terminology. So for example, some of the services we talked about in pharmacy, such as immunizations, med reconciliation, comprehensive med reviews, those are all clinically coded in these SNOMED codes so that what our service we do can be transmitted electronically and also document what occurred in that procedure. What has been developed by software providers and has been slowly growing in our dispensing software systems is the ability to do what's called the pharmacist e-care plan. And this e-care plan allows us to document what we are doing in these pharmacy services and exchange it with larger payers and providers like physicians. Traditionally, if you think about what's the difference between a pharmacy e-care plan and a SOAP note, a SOAP note is our traditional way that all healthcare professionals were taught to document. When we are seeing a patient, we collect subjective information, such as things the patient may tell us in their history, symptoms they may report, procedures of how they keep track of their meds. Objective is information that can be recorded and legitimately evaluated, such as vital signs, blood pressures, heart rate, glucometer readings, lab readings. Assessment is what we do with that subjective and objective data to identify if there's any drug therapy problems and if an intervention is necessary. And the plan is what we write out to the physician, to the payers, explaining what our plan was in taking care of that patient. The pharmacy e-care plan takes that same type of style but puts it into a more electronic format. In a pharmacy e-care plan, we are collecting information like the demographics, just like we do when we fill a prescription. We get the date of birth, whether the person is a male or female. If everybody's under the certain plan, we are listing who is the provider, who's the spouse, who's the child. In an e-care plan, though, we are going to use these clinical procedure terminology codes to identify what type of encounter occurred. So, for example, if I was doing a chronic care management service, I would document that it is a chronic care management service. If this was, also additionally in most all e-care plans a pharmacist is doing, is going to counter the prescriptions that we either fill or we document that the patient is taking. So in an e-care plan will be a med rec listing the medications the patient is on. If you've ever been able to participate yet in a MREXA medication therapy management clinical service or an outcomes MTM, you'll see that one of the things we have to document is that updated med list. The other thing in the e-care plan, we have to identify what are the centered goals we are addressing today. So, for example, if we were doing a diabetes education program, we would want to document that our goal today is to discuss how diet can relate to, improvement outcomes with medications. Health concerns. We also document in the e-care plan any drug therapy problems we identify, whether it's drug therapy problems related to the effectiveness of the drug, whether it's the adherence or the safety. We document in the e-care plan what was the intervention, who do we contact, and in the e-care plan we can document the health status of the patient by documenting objective and subjective data and listing the outcomes of what occurred. An e-care plan has four main areas. There's the collection phase, where we collect the demographics, the payer information, the allergies, the med list, their social history, their whether or not they're a smoker, a drinker, and also collecting any other subjective, objective data. The collection is the one part of the e-care plan because the collection is what we use to help provide the rationale if we do identify a problem. E-care plans, how they differ from SOAP notes, though, is any type of clinical code, we're also focused on what is the ultimate goal. So the goal, for example, as I said in the diabetes education program, is to improve a patient's maybe hemoglobin A1C or improve their education understanding of how their disease relates to a certain aspect of diabetes care. Our health concerns are those things that we identify, such as patient being misinformed, prioritizing problems, drug therapy problems, and education and interventions we may need to do, or referrals that we do for the patient, refer them to other providers. The final box is a health status evaluation outcome, that when we see the patient the next time, evaluate what goals have been resolved, what things have been concluded, and how did our impact of identifying health concerns impact the overall personal goals of the patient. Let me go back one step. So, one of the things that's important, that whatever type of services you're delivering, you want to find out what information needs to be collected for that service to be payable. And the other thing is, you want to familiarize yourself of what software needs to be used. For example, in our Pennsylvania Pharmacy Care Network, anybody that has a contract with our current provider has to use a software program called Strand for documentation. We also have internal services we do, such as immunization, in the pharmacies that I work with, and we use our pharmacy dispensing system, Pioneer RX, to document things such as, interventions we may do, flu vaccinations, signing people up for med synchronization, med reconciliation in transition of care programs. So the documentation is important before we ever think about billing. A couple things we need to think about in terms of billing a clinical service, such as a pharmacy service. One, just like anything that you do in business, if you're accepting Medicare or Medicaid type of contracts, it is very clear to understand that if you're collecting payment from Medicare or Medicaid, that you cannot offer the same services for free. So you can, and in addition, you cannot collect or charge less of what you're being paid from Medicare or Medicaid. Some billing basics to understand. The majority of billing for a pharmacy service needs to be done either through a registered pharmacy or a recognized provider's office. Because pharmacists currently are not listed as providers, the pharmacist either bill through a pharmacy provider's number or a pharmacy provider who has a contract, or they bill through or have the physician bill for their service through their provider number. This is important. And the other thing is, when we are billing, whatever we are billing, we have to use the appropriate clinical procedural terminology codes. The other thing, when we're billing, we need to consult with the payer of things such as who is eligible for the service, what qualifies a person to be eligible, and any specialized training or credentialing we may need before we can deliver the service. If you see at the bottom of the slide, I have the link for CMS's link to be able to obtain a National Provider Identifier number. For many of you who work in pharmacies already, for us to bill insurances, we have to have the physician's National Provider Identifier number. However, when you graduate, you can log in and get your own NPI number. Currently, right now, as I said, pharmacists are not listed as providers, except if you live in certain states. And whether it's when we do get provider status, or if you're living in one of those states that offer provider status for pharmacists, how you will bill for those services once you have provider status is using your own personalized NPI. It doesn't cost anything, and I always encourage people to get your NPI now. And the other thing is, every time we're fighting for provider status, the pharmacy organizations, we provide lists of pharmacists who already have an active NPI number and how we're waiting in the wings just to get provider status so that we can bill for our services. Pharmacies also have NPI numbers, and that is traditionally right now, you'll either use the pharmacy's NPI number, or if you're partnering with a physician with a clinical service agreement, collaborative agreement, the physician would bill under their NPI number. Another thing you have to understand, and this is important, and we're going to talk about evaluating the cost of a clinical service here in the upcoming slides, is you must understand that a clinical service is only billing for the time you are with the patient, and that is all that can be directly billed. A lot of these clinical procedure codes that we bill through physicians and partnering with the physicians are timed, and that billable time can only be the time we spend with the patient. Non-billable time, such as conducting reports, marketing, support staff time, all of that stuff is not billable. So when you are evaluating a service, you need to look at whether or not the service is going to bring enough revenue to cover all your other time. The other thing is, that is why you need to have a good workflow, like we talked about in prior lectures, because you have to learn to be efficient, to learn to utilize support staff so that you can control your costs, so that when you are billing for these services, it is a profitable or at least break-even entity for your company that you're working for. Under these CPT codes, there's many of them. But for example, how would I bill for a medical service? Well, these are the codes that are tied in to MTM. These are listed in the CMS registry under the CPT code registry, and there are three codes. There's 99605, 99606, and 99607. The way that it works is, when I first initially see a patient, I would bill the code 99605. If this was a 30-minute visit, I would then tack on the billing code 99607. If it was a follow visit, it would be 99606, and we'd also add 99607 if there was an additional 15 minutes. Now, depending upon what payer is paying, depending upon who I'm partnering with, these codes are then assigned a value of what I'm going to get paid. It's important, too, that different codes have different eligibility requirements, and different codes can only occur in certain settings. And so there are some things we can do right in the community pharmacy, like we can get certified to do diabetes self-management training, and if the person is eligible under Medicare, and we have a Medicare B billing license, we can bill for this service. But certain services that fall under physicians, we have to partner with that physician, and some of those services we can do remotely, like chronic care management, but the physician has to bill on our behalf using those CPT codes that are assigned to there. This is just a snapshot of comparing what can occur in different settings. So for example, remember, it is not the pharmacist that is billing, but it's either the pharmacy or the physician's office. Because a pharmacist is not a recognized provider. So for example, in the pharmacy, we can do chronic care management, we can do transition of care in partner with a physician, but it's the physician who is billing for these. In the pharmacy, the pharmacist and the pharmacy can be recognized as a provider if we have contracts to do MTM, or if we have contracts to do diabetes education. Evaluation management is contracts that you might have, say, with pharmacy care networks to be able to do different comprehensive med reviews. In the physician's office, in partnering, we can do lots of other things. We can do certain evaluation management assessments. We can do chronic care management. We can do annual wellness visits. We can do diabetes education. In the pharmacy, we can only do things such as MTM or evaluations. So it's important the location and the service is also dependable. Other things that, like I said, there are opportunities through these pharmacy care networks to actually, the care networks contract with certain payers, and those certain payers are willing to pay for those who are in the care network. There's other ways that pharmacies can bring in revenue is direct immunization billing. Most of the time when we bill for immunizations, if we are Medicare B certified, not only can we bill for the immunization of the product, but we can bill for the administration code, the administration fee for the time it's going to take for us to evaluate the patient and to administer the shot. Some different contracts may pay for adherence packaging, additional revenue to pharmacies that do MedSync. There's opportunities to do point of care testing through collaborative practice agreements and billing Med B to do things such as strep testing. And those are direct revenues that we may get for, contracting with, physicians to help improve their HEDIS measures. Some indirect revenue can occur as if we have services in our pharmacy that help improve the patient's adherence. By improving the patient's adherence, we may improve our reimbursement contracts that we get from payers who may penalize us if our patients are not adherent and we lose money on the prescriptions we actually fill. So it's very important that when we are billing that we understand what we're allowed to do and what we need to document in order to get paid. The one thing is many third-party payers will pay a set fee regardless of time. And so, like I said, you only can bill for the time you spend with a patient. So we have to be very efficient in our workflow, utilizing technology and technicians and support staff. If you've ever visited a physician, what are some of the things that they do? When they come into the office, they usually bring their laptop, touch screen, and they're coding while they're talking to us and evaluating, taking advantage of multitasking to be able to document so that they can bill for that service, and they are using time management. The more efficient you become at doing clinical services, the more efficient you become at doing good med histories, using that patient care process, the better you will be in your ability to get a service done, to be able to bill for it, and not to lose money for it. This is an example of billing CMRs. So, for example, a certain contract may pay us $52 for initial visit, the first 15 minutes, an additional $24 for that just one day. A follow-up visit may be $34, and or certain contracts actually will pay you and this is kind of like our pharmacy care network pays, is you get paid a larger fee for a comprehensive med review, and for each drug therapy problem you identify and resolve, you get additional money. So there's multiple ways you can bill for pharmacy services. The next couple slides I'm just going to share with you are ways pharmacists can get paid for doing that Incident 2 billing with a physician. I will be posting under Exam 2 a copy of an article talking about Incident 2. It came out several years ago, and it was an ambulatory care clinic in Asheville, North Carolina, and it talked about how pharmacists, in partnering with physicians, were able to bill for different types of codes, such as anticoagulation, osteoporosis evaluation, pharmacotherapy, med therapy management, and wellness visits. And these different codes were also paid based upon time involved and the level of effort. And so there's examples of the reimbursements can vary anywhere from $19 to $133 per service. Several years back, I categorized some of these popular services that pharmacists can deliver either by themselves, such as DMST or med therapy management, or by partnering with a physician. And this is just the tables of listing all those different codes. So that is how we bill. The key thing is, when we are developing a service, there is opportunities to also have a standard pricing based upon what people might be willing to pay just by cash or out of pocket. But in order to determine how will you price for a service, you have to think about several different business principles. Now, these next couple slides, I'm not asking you to walk away from this being a business expert, but I want you to appreciate what goes on in developing a service and pricing it right and marketing that service. So key principles for pricing would be we would want to project what's the volume of patients or patient encounters we can do with this service. How are we going to price this service? Understand to evaluate, will the service at least break even for us that we can cover our operating cost? And for who we are partnering with, whether it's ourselves, our business, our boss, the payers, the patients, and the providers, what is the return on investment for doing the service? So in order to do this, we need to evaluate our market, and marketing will help us with our financial projections. Back when we talked about the business plan lecture, we talked about evaluating the market. Who would want for this? Who would want to have this service? Who could be eligible for this service? What are our competitors? Who out there could also deliver this service that may take away volume of us offering the service? Looking at a SWOT analysis of strengths, weaknesses, opportunities, and threats of our service, and determining, maybe in that first year or two, how much market share, how many people, for example, if there's 100 patients of a physician's clinic that could benefit from our diabetes service, we have to be realistic that all 100 probably would not use our service initially. So we'd want to make projections of if 20% of them used our service, what would that look like? We also talked about in the business planning about recognizing the need of why we'd want to do this service, establishing specific targets to evaluate if this service is needed, developing clinical and operational goals and objectives to make sure we can measure the success of the service, both in the clinical, economic, and humanistic outcomes. We need to have a good workflow of the who, what's, and wheres for this service, and we're always going to be testing and revising the service, and definitely we need to market the service. And when I mean market the service, who will want to use the service? Why would people want to partner with us, such as providers and payers? Your take-home assignment that will be due a week from this Saturday is an article I want you to read, and it's called Using Relationship Marketing to Expand Pharmacy Services. And what you need to do for this take-home assignment for your class participation is to read the article and to answer the questions at the end of the article and submit it, which I have listed for you on Blackboard. And in this article, it talks about the need for pharmacies to do what's called the purple cow, to find the niche of what is a service that people would want to partner with pharmacy, and how can we promote this service for people to want to have this service from us. In this article, it talks about the P's of marketing, the product that we are delivering, the service we are delivering. How does this differentiate from some other type of service we can get? The price. What is the value of this service? Obviously, for any of these services, we need to cover our intellectual and our time as pharmacists, but what is somebody willing to pay for this service? How are we going to promote this service? Not just to patients, but to physicians who we want to use this service, and for payers that we hope to pay for this service. The place. Where is this service going to be located? How will people feel comfortable coming to the pharmacy for this service, or will we need to go elsewhere and bring the service to the patient or the provider? And the fifth is positioning. How does the product or service will be viewed as a personal benefit to the prospective patient? A lot of this successful marketing I find in healthcare and in pharmacy services is developing a core of relationship marketing, word of mouth, getting to know your physicians, getting to know your patients, that they can trust you, that the service you're going to deliver is going to solve their problems and make them feel good. So relationship marketing is one-on-one marketing. Some of the ways that I've been successful in certain services that I've done is by talking to physicians directly at their offices, taking them out to dinner, learning how our service can be a win-win for them, and getting patients to want to use this service. Just simply sitting down and talking to our patients, going to do talks to church groups, senior centers, and having them understand the benefits of wanting to use this type of service. In target marketing and niche marketing, we want to identify the most promising market segments. Example, what type of patients would benefit from, say, a diabetes service? Why would physicians want to partner with us? How can we show physicians that our service is going to provide a win-win to them? So what is that niche of why people want to use our service? As I said before in the business planning lecture, services need to answer two important questions. How does this solve the partner's problem? And how does this make the partner feel good? And who we are marketing is multifaceted: the patients, the healthcare providers, and the payers. The other thing is, when we're partnering with all these different entities, we need to show that these are worth investing, that the return on investment is going to improve patient care and clinical outcomes. Return on investment is the following: does the cost savings of the service, or does the revenue that this service brings far outweigh the total cost to operate this service? And that is the return on investment. I know most of us went to pharmacy school not thinking about business. We went to pharmacy school thinking about we wanted to take care of patients. We wanted to have that clinical knowledge to be able to take care of patients. But in order for somebody in the pharmacy realm to want to develop these services and make these services viable, you need to have a business setting on you. Just like in a traditional community pharmacy, in order for it to stay afloat and to be able to pay its workers and stay in business, it needs to bring enough sale revenue in to cover operating expenses and product, and hopefully there is a net profit to keep the business afloat, to reinvest, and to reward those who have invested in this business. In the community pharmacy world, there are numerous formulas to evaluate what does it cost to fill a prescription. And as we talked about in prior lectures, those pharmacies, to be efficient, need to be good at inventory management and also in utilizing workflow to the maximum. When we talked in the business lecture, we need to financially plan for a clinical service in the very same way. We need to think about what does it cost to deliver this service, such as the salary, the service personnel, the materials and supplies, direct costs, and indirect costs. An easy thing to first do is, as I said earlier, marketing can help you with your financial projections. So for example, if we know how much we propose that we're going to do of this service in a certain time frame, such as a year, and what we're going to price for this service per customer per year, we can calculate what the total revenue we're going to bring in. And by calculating this total revenue, this can help us determine what resources we may need, what's the cost of the resources. We can set a budget and for our service. One of the things I propose anybody when you're doing a clinical business plan is to do a 3 to 5 year plan projection. So you want to be able to look at both the best scenario and the worst scenario. So, for example, if I was doing a diabetes program, which I hope that the patients would actually improve their testing, I could look at, for example, if I was doing this at a community pharmacy, I could run a report of how many patients do I have that are diabetic based upon the medicines they receive. I can then look at how many of those patients are actually getting testing supply, glucometer testing supply from us, and say that maybe only 25% of them are. So maybe then our projection is with our education program, we're going to grow 25 additional percent of patients to get testing supplies from us. So, for example, if we had 100 patients and only 25 of them got testing supply, but we hope with our educational programs, 25 additional, we would take 25 patients times 12 months times whatever the cost of dispensing, and that would be our annual gross revenue. But it's important, whatever type of services you're trying to develop, you realize you're not going to capture all of the market share at first. You can also do these same types of proposals in inpatient setting. For example, if I was a hospital wanting to start an anti-coag clinic, I could look at the past year of how many patients came into the hospital that were on some type of anticoagulation. I may look at what was the percentage of bleeds reporting due to this anticoagulation. So maybe I projected my service is how many patients am I going to see and what would the savings be of my service. And so there's numerous ways we can do proposals and evaluate. As I said, projections should be done each year after the launch of the service. The size of your target market and market share must be modified from year to year. Target market might grow due to population growth, change in disease incidence, or change in rate of diagnosis. Market share might grow due to the increased rate of the adoption of the service. So we always should do multiple different scenarios. What is the worst case scenario, of like if we only got maybe 5% of the market share? What would the best case scenario be if we got 100%? When I was evaluating our first contract with the Pennsylvania Pharmacy Care Network, I ran a report of how many patients would be eligible for this service. Now, this first contract with this first payer, the way they paid, they would pay for one comprehensive review and for 6 additional follow-ups. So what I did was I created several different scenarios. What if every patient that came to my pharmacy that qualified got that one comprehensive review plus the 6 follow-ups? That was my best case scenario. And then I did scenarios of what if I only got 10% of that population, 15% of that population. And by doing these different scenarios, I could look at what my total annual sales would be of revenue, and I could start looking at also my operating costs and projections. Because it's important that whatever pharmacy service you do, it shows a return on investment. It's either having enough cost savings or bringing enough revenue in that outweighs the cost to deliver the service. So in developing these financial projections, there's multiple different ways we can look at it. The service could be something that just generates revenue, just like billing for MTMs, immunization, annual wellness visits. If I'm an inpatient service or I'm partnering with, say, like an account care organization, I might look at how much I'm going to decrease healthcare costs. You can also, your service could bring in both, but the financial benefits are expected to be greater than equal to the costs to provide the service. Many clinical services, as I've shared with you, have financial benefit. I've showed you that many studies have shown for every dollar invested in pharmacy services, there is anywhere from $2 to $4 to $6 gained in financial benefit. The challenge of pharmacy is that we have to have people to have buy-in for this. But if we're going to get paid for this service has to bring in at least anywhere from $1 to $3 a minute to cover pharmacist time and operating cost. Now, my personal opinion based on doing these over the years, that for a pharmacy service to be viable and to stay afloat, the billing has to at least pay the pharmacist $3 per minute. When we're pricing a pharmacy care service, we have to look at those costs that come into delivering that service, such as direct costs, which can be salaries, supplies, advertisement, certifications, licensing. Indirect costs could be support staff that may do other things in other places in our company. The square space that we use in our building, how it occupies the rent of our building, the utilities, the property tax. All of these things we need to calculate in the pricing of a service. We also have to remember, too, when we're selling this service, we have to share that our service is going to do some deliverable goods. It will hopefully, over time, decrease costs in hospitalizations and emergency department visits. Some costs may go up, such as drugs, because we're going to make patients more adherent, physician visits, because we're going to refer patients more often to the doctor, labs, and administration time. The last couple slides, I just want to provide some examples for you. The first slide here is, say that I wanted to do a hypertension clinic service at my community pharmacy. And here's how the service works. For any patient who wants to be involved in this service, they need to purchase a home monitoring blood pressure machine, one-time cost they will purchase, and I will charge them $10 per month to be able to, meet with me. I will evaluate those blood pressures that they're taking at home, provide some counseling about those blood pressures, of how they can improve it, and I will do this every month. So, for example, say that I'm trying to make projections of this, and I see that there are 200 patients. I'm going to use low numbers, even though this would probably be higher. That there's 200 patients in my pharmacy that are getting at least one hypertensive medication. So even if they didn't join my hypertension service, I got 200 patients who their average cost of their one drug is close to $20, and say that they're super compliant, that they get it filled every month. That's $48,000 in revenue. Now, I know I'm not going to get a perfect share, but say I get a little bit over 50% of these patients wanting to enroll in my program. So that 113 patients that I get to enroll in my program are going to buy one time a blood pressure monitoring machine at $40. So that is an additional $4,520. So between prescriptions and equipment sale, I have brought in $52,520 in revenue. Now, just bear with me. Usually the cost of goods sold is somewhere about 70 to 80% of what sales are. So that is why for me to purchase the medications and the supplies is going to cost about $36,000, but I'll still have a gross profit about $15,000. If I think about some of my operating costs, my variable costs between pharmacist time, rent, wages, then my net profit ends up being about $7,881 because my variable costs were about close to $7,900. Now, the next part is that education monitoring service I'm going to charge of $10 a month. And in the best case scenario, all 113 patients come to see me every month and I charge them $10. And so that's an additional $13,560 in revenue. I still have to take into what's the variable cost, the operating costs of my pharmacist wages and times to do that. And for that year, it would be around $2,000 because these visits would be very short visits. And so then my total net profit could be around $19,000 when I include prescription sales. Once again, I'm not asking you to be a financial wizard. The purpose of this example is to show you, one, we have to do projections. Two, pharmacy services can be profitable, and it can be done at even a minimal wage fee. And if we do this right, we can see revenue brought to the pharmacy and a win-win for the patients too. Because out of that hypertension service, I can do things such as evaluate how many patients' blood pressures got lower. I may be able to partner with in the future with physician's office who would actually bill for my educational services. So lots of opportunities. The next example is a diabetes care service. And so here's the example. Pharmacist Jones wants to start a diabetes care center in his community pharmacy. The Diabetes Care Center will provide counseling, educational, and monitoring services to diabetic patients. Pharmacist Jones plans for the basic unit service in the DCC to be a 15-minute counseling, education, and monitoring session. As a first step in setting up a reasonable price, he needs to estimate the cost of the session. So, what do we need to know to evaluate the cost of the service? Well, how many hours a week is this service going to run? 6 hours a week. What is the pharmacist's salary for the operation? Mr. Jones is going to pay a part-time pharmacist $45 an hour to deliver this service for 52 weeks. This owner is also going to account that his salary is going to be about 3 hours of his 60-hour work week to manage this service. He's going to have a full-time tech dedicate about 2 hours in helping with the workflow of the service, such as scheduling appointments. He's going to renovate some space in his building, and that space is going to be about 150 square feet of his rented floor space. He's going to have some renovation, and he's going to talk to his tax advisor, and this renovation is going to cost him about $18,000, but he's going to depreciate that over 6 years, so it'll only be about $3,000 per year in showing in the cost. He's going to promote some budgeting of marketing, so he's going to spend about $2,400 in marketing. And what he's hoping to do in his projected annual volume is he's going to have 1,000 sessions, and he wants to charge $30 a session. So if you take $30 times 1,000, my annual gross revenue is going to be $30,000. So let's see if that $30,000 is going to break even for that first year based on all these costs we brought in. So if I look at and divide all those costs by direct costs and indirect costs, I see the following. If you see on the left-hand side, there is the cost of the remodeling, which is depreciated at $3,000 a year. The marketing that's going to happen in that first year. The pharmacist's salary, the tech salary, the allotted time for the pharmacy manager. And so the total direct cost for that very first year is going to be $26,438. I also take into account how much of that 150 square feet will be part of the rent, how much of some of the indirect costs we'd be borrowing and using the same pharmacy system as our dispensing software. And so there is a percentage of indirect costs. So if I add indirect costs and direct costs for this service, it's going to cost about $28,481 to deliver this service. If I take that I'm projecting 1,000 sessions, it's then going to cost me to deliver the service about $28.48 per session. And that leaves me a net profit of $1.52. Now, what would happen if I only got 500 that year? Obviously, I might lose money. So the question is the following. How do we evaluate the success of the service and the return on investment? Well, we know that the return on investment, at least if we got 1,000 sessions, would at least maybe break even. There might be some indirect things we would evaluate the benefit of the service, such as the number of prescriptions we got by people maybe switching to us because they like our diabetes education program, maybe additional over-the-counter products that we can sell. Maybe we can also refer them into a larger DMSME diabetes education program. The point of this exercise is to show you that when we are looking at delivering a service, we also have to look at the economics of the service to be able to justify, is the service worthwhile? Now, in your lectures with Dr. Kamal, he's going to show you many different ways how we can evaluate the value of a service. But I wanted you to have an understanding and appreciation of what it takes into documenting, billing, and evaluating, is a service going to be at least break even or profitable. Please read that article about relationship marketing, and don't forget to do the class participation. And I will be posting a second study guide by Monday so that you guys can look at what you need to know from this lecture for exam 2. Thank you very much.